Hi, I'm Dr. Howard Jack West, and I'm a medical oncologist with a particular focus on thoracic oncology. I'm an associate clinical professor in the medical oncology division at City of Hope. And I also lead a program called Access Hope that works on remote consult services there. And I'm based in the Los Angeles area. I'm happy to welcome all of you to this multidisciplinary tumor board on a series of provocative lung cancer cases.
Hi, I'm Michelle Ginsburg, and I'm a director of cardiothoracic imaging at Memorial Sloan Kettering Cancer Center. And I'm also vice chair for education in the Department of Radiology, also at Memorial Sloan Kettering. And I'm also a professor of radiology at Weill Cornell Medical College, which is across the street from Sloan Kettering in New York City.
Hi, everyone. I'm Suresh Shamalingam. I'm a professor of hematology and oncology at Emory University and the Winship Cancer Institute. Like Dr. West, my focus is also on thoracic oncology.
Hi, I'm Seth Force. I'm the Kamal A. Mansour Professor of Surgery and Chief of Thoracic Surgery at Emory University in Atlanta, Georgia.
Hi, everybody. My name is Cliff Robinson. I'm a professor of radiation oncology at Washington University in St. Louis, and I am the chief of the Cardiothoracic Radiation Oncology Service and director of clinical trials.
71-year-old woman who previously smoked, 50-pack year history, and has been diagnosed with stage 2B squamous cell carcinoma, but has a complication of a recent femoral fracture and has undergone right hip arthroplasty. She had PD-L1 expression testing, it's 5%, and the most relevant issue in terms of symptoms is this was actually found in a preoperative chest x-ray for her hip surgery. She had a fall at home. Her performance status is 2, so on the marginal side, but this is a potentially transient fixable problem. And otherwise, her past medical history is notable for COPD, though she's not dependent on oxygen, has a history of atrial fibrillation, a history of embolic CVA, and CLL was diagnosed in 2020, but hasn't required therapy. And with that, let's turn to some of the workup. And Dr. Ginsburg, if you can just walk us through a couple of highlights here.
What we're looking at, the top image is a coronal section of a CT scan. And we see a 1.7 by 1.9 centimeter nodule, which on the image below is an axial image from a PET CT. And we see that this nodule is avidly enhancing and has an SUV of 10. In addition to that, there was a lymph node that measured 1.6 by 1.0 centimeters with a milder uptake of 2.4.
Okay. And I mentioned the biopsy, that she had a core biopsy that showed poorly differentiated squamous cell carcinoma. It's positive for P40 and CK5/6. PD-L1 is 5%. And so this is somebody who we don't have PFTs, but let's presume that that's at least that she's not especially symptomatic. Dr. Force, can you give your thoughts on how much of a proponent you would be to move forward surgically? Would you definitely require more of a pulmonary evaluation, or would you be more inclined to direct this patient toward radiation-based treatment?
So, I mean, the fact that she has a hilar lymph node and is stage 2, and that can be removed surgically, and we would think that she would, be a candidate for some adjuvant therapy, chemotherapy. I would certainly like to see if she's a candidate for surgery. A couple things, we would, because she's presenting at stage 2, she would definitely need preoperative mediastinal lymph node staging, because In a patient like this, if she were stage 3, although we can often operate on patients with stage 3, she's not someone we would probably push the limits of surgery in advanced stage lung cancer. If her mediastinal lymph node staging was negative and she still was stage 2, then she would need some breathing function test. And one thing it seems little, but it's important. Her hip fracture is on the same side as the lung cancer, which means that hip is not what she's going to be laying on during the entirety of that surgery. So we can actually protect that hip. And I've had similar situations in patients who recently had hip surgery. It's when it's on the downside that you often have to wait longer because the orthopedic surgeons don't want them laying on that. As long as she's ambulatory and has good, meaning she can walk around and get around and she has decent lung function, I think for sure she'd be a surgical candidate. And this is, I mean, she is not atypical for a lot of the patients I operate on week in and week out.
Right. Yeah, I think that's a really good point as well, that patients with at least some nuance that makes them complex are not a rare situation. There's plenty of patients who have some complicating issue to at least give pause and make sure it's a deliberate decision. Cliff, what's your thoughts? I'm also very interested in the question of how much of a drop-off is there in your level of enthusiasm or, a change in approach for someone with what appears clinically to be at least N1 nodal disease?
Yeah, certainly somebody with N1 nodal disease cannot receive standard SBRT the way that we think of it. So when you deliver SBRT to a primary lesion in the lung, typically it's in 5 or fewer radiation treatments. When you start to involve things like the hilum, or for central tumors that are what we call now ultra central, meaning that they're literally touching or within the scope of the bronchus or esophagus region as well, we have to continue to dial down the dose per fraction and increase the number of fractions. And while there's evolving data that suggests that that's certainly doable, it's not certainly optimal for the fully ablative doses that we prefer to give more peripherally. I will say, however, if this woman was to have other features that were maybe not here, that, after Dr. Force said that she was maybe not the best operative candidate, and we were forced to consider doing something, I do think that the initial mediastinal and like an EBUS FNA and sampling of the node would be very helpful.
Yeah.
We have many patients that we have reactive lymphadenopathy. You can see that, at an SUV of 2, while we certainly wouldn't want to ignore it, it's possible that it may in fact be reactive. And if we can eliminate that as a possible lymph node station, then it opens up the door to treating just the primary itself.
And I think that that's a good point, because especially with squamous cell cancers, which tend to be more inflammatory lesions, we often see reactive nodes. And just one other point I wanted to make is that it is also very important where that node is in the hilum, because if it's below the upper lobe airway, it could mean that she would require a pneumonectomy to get out all the cancer, to get that lymph node out. So it's very critical where in the hilum the node is. If it's near the airway that's coming out with the upper lobe, fine. But if it's not, then it could require a much larger operation that she likely would not be a candidate for.
Ram, what's your thoughts on the role of post-operative therapy for someone who is a marginal candidate? I mean, it is a standard of care with a survival benefit. Say she undergoes surgery and has an N1 node involved, but it's non-trivial to add the adjuvant. Adjuvant literally means helper, and we're talking about single digits improvement in survival overall in the broader population. So do you have a general inclination or disinclination, or is it completely individualized to the patient? And if so, this patient, say.
Jack, in general, as you know, the standard of care for early stage, specifically the role for adjuvant chemotherapy, is for patients with tumors that are larger than 4 centimeters and or positive lymph node involvement. The more the number of mediastinal lymph nodes that are involved, or even submediastinal nodes, the higher the likelihood of recurrence and subsequent mortality related to lung cancer. Now, having said that, the best evidence is to use cisplatin-based chemotherapy in these patients, And just knowing the details that you presented about this patient's situation makes me wonder if this patient can undergo cisplatin-based chemotherapy. My feeling is no, the patient will not be a candidate. Then it boils down to, is the patient a candidate for carboplatin-based therapy, which we would all agree that is somewhat suboptimal, but if we had to give somebody some chemotherapy and cisplatin is out of question, then we would proceed with carboplatin-based therapy. So for me, the question would be, when this patient is done with the surgery and we have the final pathology report, A, what is the extent of nodal involvement? B, how did the patient fare during the surgery? And 4 to 6 weeks after surgery, what's the patient's functional status? And did the patient have any complications post-operatively? And if the patient came out really well and looked to be in a reasonably good condition, then I would consider carboplatin-based therapy for this patient. But I would say that just based on what I've heard so far, I would be very reluctant to consider chemo in this situation.
And I would just add, I completely agree. The data that we have, the strongest international data in multiple trials is with cisplatin. That is certainly my preference, and I think most thoracic oncologists. But there have been trials that have used carbo that have had hazard ratios that are not wildly off from what we've achieved with cisplatin. And I think that part of our strong preference is the precedent that that's what we've studied far more. I think feet to the flame with a whole array of trials of cis versus carbo, which we've largely moved away from in recent years, but occupied at least a decade of our time and debating. I would say cisplatin is marginally superior, but in somebody who, because of renal function or performance status, we think that would be too ambitious, I would not hesitate to consider carboplatin an acceptable substitute, even if not the preferred one. Yes. And also, when along with the other factors you mentioned about postoperatively, we can see whether the patient had 1 lymph node involved or 4 or something like that. These are also factors that we would potentially use.
Absolutely.
Any other comments people have before we move on to the next case?
One of the comment, I think, and we discussed this, I think Dr. Robbins brought up, but it is very critical to understand that a lymph node or something that shows up on a PET scan does not guarantee that there's cancer in it. And the point was made that, we would want to biopsy that lymph node to confirm that. So I think that gets overlooked a little bit. And sometimes people are considered not candidates for certain therapy because they're assumed to have more advanced disease. But pathology is really the key. It's very important to have a pathologic diagnosis, if you can, of not just the tumor, but the accurate stage.
Potential false positives and false negatives. Of course, we can't be assured that, we've alluded to this, that just because it's not screamingly positive on a scan doesn't mean that someone doesn't have N2 nodal disease either. Right.